Good afternoon and welcome to this afternoon's session. The heading of the session is moving towards integrated community and primary health systems to improve outcomes for women and children affected by TB and TB-HIV. And we're really wanting to stimulate discussion and get your creative thoughts around this topic. My name is Marion Loveday. I'm from South Africa. I work for the South African Medical Research Council. And I'm going to ask Anna to introduce herself.
My name is Anna Detjen. I work for UNICEF as a childhood TB focal point.
So we've got 4 speakers today. Anna's going to start, and then we're going to have a perspective from Uganda, and then Sabina Fakale's going to speak, and then I'm going to finish off. So I'm going to start just by introducing Anna to you. She's very special, actually, and was referred to by Stephen Lewis in the plenary session which opened the conference as the sole UNICEF person who does anything to do with childhood TB. So we're very honored to have you here. And I think without any further ado, we'll start.
Thank you, Marianne. I was humbled, but also agreeing with the criticism that came towards my organization doing even more. But I'm the only one who actually has a job description of TB. There are increasingly people at UNICEF that get engaged. Can we have the first presentation up, please? So, I need to say we have 5 presentations today. We have also some update from WHO on how they plan to actually provide some guidance on integrated activities. And then I have to apologize to all of those who have me heard talk about this, because I was asked 3 times to talk about the same topic. But it's only me who's going to be repetitive. The other things are all new, so please bear with me and stay. So I really want to give you an update on childhood TB integration. In the roadmap for childhood TB that hopefully many of you know, that was launched in 2013, there's a call, amongst many other things, for more engagement of important actors that have not yet been engaged in TB, and for better patient-centered, integrated, family-centered approaches. So there were a lot of discussions and events over the past year that I want to summarize and share some of the thoughts and key messages with you. We held a meeting in New York at UNICEF in collaboration with WHO and TB Alliance on strengthening community systems for childhood TB. And we really brought together a very broad range and actively reached out to hear how maternal and child health, nutrition, HIV stakeholders, but also people who work in health systems and community health systems think about us wanting to integrate. Then there are 2 case studies that Sabine is going to present, and there was a global conversation on the MSH LeaderNet platform earlier this year, which was really a very interesting global dialogue with participants from, I think, over 15, 16 countries. So I have no conflict of interest to declare. So we always say we want to integrate, but what does that actually mean? So there are many different perspectives from the patient who just wants to have comprehensive care and not go to 5 different places. And we know that even in TB and HIV, even though we've talked about integration for a long time, this is still an issue, to the policymakers who really have to prioritize what it is that they need to do, to the donors that need to be more flexible and coordinate their investments so that we can build comprehensive systems. So integration should be seen by us as a strategy that can help us to improve outcomes for children with TB, but also to strengthen health systems. And this is something that we share with these other actors that we're reaching out to. So that's one of the common issues that we're all dealing with. So it's a strategy that's going to help us to improve health and care and reduce overall cost and make things thereby scalable and sustainable. So we have also to look at different perspectives. What's our perspectives? Why do we want to integrate childhood TB? If you look at the pathway of a child affected by TB that starts in the community, that's a high TB burden community, the child might be infected. If all goes well, then TB will be prevented. But all too often things don't go well. Children don't access the system. They might access it later when they are sick, but then they are often not diagnosed. And then some of them are cured, but not all. So we are dealing with many, many gaps and challenges, from a lack of awareness, an access gap, the prevention and diagnostic gap that again came out in the Global TB report that was launched 2 weeks ago. And most of these things along this pathway, and the first interaction with the health system doesn't happen at the TB program. It happens at the primary care level, at the community level, where patients should be accessing care. And the TB programs in general don't really have a good reach into that system. So there's really a need to integrate at that level and build on platforms that are actually existing and being strengthened as we speak. Then we have to look at the context of the maternal and child health and primary care programs. So maternal and child health is very much driven by the Sustainable Development Goals, and the focus is more and more on maternal and newborn health, adolescent health, NCDs, but there's also a really, really important unfinished agenda where pneumonia still causes about 1 million deaths every year in children under 5, and malnutrition is a cofactor in about 45% of the under 5 deaths. It's also not that the existing primary care system is ready to receive and integrate more and more things. The system in many countries is already overburdened and not necessarily functioning well. So the question that we get is, why should we integrate and who pays for it? Because there are also funding limitations. But there is a recognition amongst the MCH actors that with the changing epidemiology of common childhood illnesses, the scale-up of pneumococcal vaccines, that this might actually lead to unmasking conditions such as TB. So what we really need to look at, and what researchers need to look at, is what is the impact of TB on some of those key maternal and child health outcomes. How much does TB contribute to pneumonia? This is the reason for why the maternal and child health community is really focusing in on the lowest level health systems, the community system. So it shows that if a package of interventions is for maternal, newborn, and child health is implemented at the community level, this can lead to the aversion of 77% of maternal and child deaths. So there are strategies developed, there is money being put up to address this, and we have to become part of that packages in the setting where it's necessary. So we have to define where this should be happen, and we have to be very clear about in priorities what it is that we want to see at that level. So going back to our pathway, there actually, and this comes out of the discussions that we had over the course of this year, there's an agreement amongst all of us, including those that we want to integrate with, that there is a large role for those providers at the community level, community health workers, as well as the supportive systems, including patient groups, mothers groups at the community level, to get involved, to increase awareness, to ensure that children access the health system through contact tracing or services for sick children, and that it is really because we don't have a point of care and an accurate diagnostic test, that it is the diagnosis and the initiation of treatment that might have to happen at a higher level. But even after that, it is the community service, the primary care services that should provide follow-up and treatment support so that we reduce the burden on the families and also create a more efficient system. So, but then the question is, how do we actually do that? And this is, again, one of our confusiograms from one of our meetings, where we talked about which are the interventions that are present and strategies at the community level, what are the TB interventions that would make sense, and what are the considerations when we start thinking about how to do this. And these considerations, most of them have to do with broader health system issues. So what are the policies? How do we jointly approach things? Ensure that childhood TB and integration is not only addressed in TB guidelines. That doesn't work. If we say in the TB guideline that children with malnutrition should be screened for TB, that does not mean that the nutrition people take that on as their responsibility. Trainings, how can we make it more efficient so that there's a joint training, that the tools that the community health worker in his small backpack doesn't have 5 different management tools and 5 different registers from each disease control program, but there is one. So it's system issues that we should be addressed. The one thing that we all realize is that when we think about integration, or when we think about what we need to do to integrate childhood TB and to improve care for children with TB, we think about the services that we need to implement. We say contact screening, risk assessment, this and this and that. But in order to implement these services, we need a system. We have pilots that show effectiveness of interventions. And we pilot and pilot and pilot, and the pilots don't get scaled up because it takes a system to scale up. So This needs to happen so that things can be implemented. We need to understand the pathways, the actors, and it's not only important for sort of the integrated approaches. It's especially important for those because it involves this broad range of stakeholders. But it's also something that we're really all struggling with, and in the end, what we want to move to is to start with a child that is sick and take care of it. So there are many things to move forward. What we need is really leaders and champions that are reaching out to the much broader community amongst child health. We need coalitions and strong coalitions with maternal and child health, nutrition, HIV communities. We need a lot of evidence, not only on the burden and of the burden of TB and its impact on maternal and child health outcomes. We need operational data on how this can happen, because there are a lot of issues, and if you go to the poster area, you can see some of those. We need to identify which interventions actually are effective or not only efficient, are efficient, not only effective. And then we need very clear and goal-oriented priorities to not get distracted and to do something that's feasible for systems that are overburdened and have a lack of human resources and a lack of finances. And resources is obviously another big issue, that how can we be flexible and creative and discuss with the donors that even disease-specific funding can be used to strengthen the broader system. So thank you very much.
So what we thought was we'd just take now 1 or 2 questions of clarity and then rather save the discussion for after all the presentations at the end. So are there any questions just of clarity now for Anna? No, you're off the hook.
Okay, so I'm going to introduce our next speaker. It's Maureen Sekade. She's the childhood TB focal person with the National TB Control Program in Uganda, and has really taken a leading role in Uganda to sort of show us the way forward on some of these initiatives that we can do.
Good afternoon to you all. So as mentioned, I coordinate childhood TB activities in Uganda, and I am seated at the National TB and Leprosy Program. So I'm here to give a Ugandan experience on childhood TB case finding and prevention at community level. Just as a background, for us who don't know where Uganda is, it's that little red country in the middle with about 34 million people. Half of the population is children under 15 years, and 80% of them are in the rural setting. Our current TB incidence is at 234 per 100,000, which is higher than what was previously estimated by WHO, about 160 per 100,000. Our HIV prevalence among our children under the age of 5 is 7.3%, but the country is currently doing another AIDS survey, so we are looking forward to the results. TB-HIV co-infection is at 42%, that is at a clinical level. So our childhood TB program was intensified in 2012, and we've gone through so many activities to where we are now. Starting with the childhood TB focal point at the TB program. We have a technical working group that is under the TB program, which has really given us a good opportunity to really scale up these activities. We conducted a baseline assessment that has informed our scale-up of quality services. We now have guidelines, training materials, and our reporting and recording tools have actually incorporated childhood TB. We are able to disaggregate data for children by HIV status, by disease type, and treatment outcomes. And we are currently doing trainings up to health facility level. So what is our notification like? In 2015, we notified about 2,900 cases, and this contributed to 7% of the total TB cases. But again, this is quite low, given the estimate of about 15 to 20% in the high-burden countries. As far as drug-resistant TB is concerned, we are notifying about 3%, which is also similar to global level. Majority of the cases are clinically diagnosed for reasons that I will not go into at this point. So I thought we would also appreciate our organization structure. We do have the Ministry of Health at the top. I'll start from the bottom, sorry. And then we have the district health services where the district health officer is situated. Then we have a regional referral, district health services again. And then we have referral facilities, which is a health center 4s and hospitals. And then health center 3, health center 2, and community level. So as we go through the experiences, you will appreciate this cascade. So at the central level, excuse me, we have different opportunities where childhood TB can actually be integrated. I must say that we have not really tapped into this like we should do, but the TB program is working with the AIDS control program, which is down on the left. And then we are closely working with the maternal child health. We are working with newborn school health, but the degree of integration is really not what we want it to be. So we are slowly moving there. Nutrition has also been a gap that we are trying to really push for. And then we have the community level where we have the village health teams and health promotion. Then clinical services is also another area that we are trying to push for, especially for access to radiology services. So what have we done to decentralize our diagnostic and management capacity for childhood TB? Like I said, we have different levels: central level, regional, stroke district, health facility, and community. So at national level, we do have a coordination, and this starts with the technical working group that has brought on board academia, researchers, clinicians, civil society, so we meet quarterly. And then we have also had a national training of trainers sessions on the management of childhood TB. And these have gone on to the regional level where we do have a coordination. And here we have found that working with the district is critical. It doesn't make sense to, come from central level and say do ABCD. We need to plan with them. So working with the district right from planning and through implementation has really given us an opportunity to better implement these activities. And then as far as diagnosis is concerned, we do have gene experts at regional and district level. We have about 100 or so machines that have really helped us in pediatric diagnosis. Of course, majority are clinically diagnosed, but at least it's a step higher than microscopy. Then we do have mentorships, support supervision, both by central level and regional and district mentors. So our training has taken an approach whereby the national trainers train the regional trainers. Then the regional trainers are the ones that do the facility level trainings. Through previous experience, we have learned that taking health workers away from the facility kind of interrupts the services at the facility. Then you have very few at a time. But when you find them at the point of care, you're able to mentor them hands-on. The patients are there, so they are able to appreciate these things. And then as far as our community interventions are concerned, we do have contact tracing, but it is mainly active for drug-resistant TB. So we still have a gap for drug-susceptible TB. I will then talk about the innovations that we have put in place to strengthen community interventions. So what is DETECT? So DETECT Child TB stands for Decentralized TB Services and Engage Communities to Transform the Lives of Children with Tuberculosis. So this project is being implemented in collaboration with the TB program, the Union, Mildmay, and Baylor, Uganda. And the project goal is to strengthen health facility and community level healthcare to improve child TB case finding, treatment, and prevention. So we are implementing this in rural and peri-urban settings, 2 districts, so to say. So our project objectives are to improve capacity at the different levels of care, to increase TB case detection among contacts, to provide preventive therapy among those who are eligible, and to improve treatment outcomes for children with tuberculosis. So this schema is just showing us the activities for DETECT. So the entry point is the health facility, where for every patient diagnosed with tuberculosis gets contact tracing done. So the index TB case, so when the facility diagnoses TB, they call on to the village health teams, and these go on to the household to screen everybody in the house, not only children, but also adults. And so those that are asymptomatic and are eligible for IPT are referred to the facility for IPT. Those that have symptoms for tuberculosis are also referred for further evaluation. So at the facility, the health workers have also been trained to screen and to further evaluate these children, be it adults, for tuberculosis. So what has Detect really achieved this far? So when you look at the left graph, it is showing Wakiso district, which is the peri-urban district. So the first bar is the baseline. So majority of the cases at the baseline were being diagnosed in the hospital. That is the blue. Then we had very few coming from Health Center 4s and Health Center 3s. But as we have implemented Detect, you see that there is a change in the number of cases that are actually coming from the lower level facilities. And the same applies to Kabarole district, which is the rural setting. So this has shown us that once you build capacity, you mentor these health workers, you supervise. Now, when we did the first training, the cases were not forthcoming. The clinicians did not have that confidence for clinical diagnosis, but with continuous mentorship. Without the mentorship, then the confidence is not really going to be built. Okay, remember they are using just symptoms, X-ray findings if available, to really initiate TB treatment. So then we have another project, which is an integration of TB-HIV into ICCM. ICCM stands for Integrated Community Case Management of Children, and these are children under 5. So ICCM targets diarrhea, pneumonia, malnutrition. So together with UNICEF and WHO, we are integrating a component of TB and HIV to identify those children that have history of contact, okay? Because we do have some districts that are implementing this ICCM. So the objectives are to assess feasibility and effectiveness of integrating TB-HIV into ICCM, and we are targeting children under the age of 5 years. So in the training materials, we are just asking one question: is there a history of TB contact? And if there's a history of TB contact, that child is then referred to the facility. For HIV, we are asking, has the child been tested? If yes, was the test positive or negative? Is the child on ART? Are the parents tested? And if we identify that there is a child who is at risk for HIV, then this child is also referred to the health facility. So we are not doing HIV testing in the community. So that's the schema for TB-HIV ICCM. So for the ICCM project, we are starting in the community. Remember, for Detect, we are starting at the health facility. And then once they get to the health facility, these under 5s are further evaluated for tuberculosis and managed according to the guidelines. So this was just meant to show us how these two projects actually work together to achieve the same goal. So on the left-hand side, we have Detect, which starts at the health facility, ends up at the household level. On the right-hand side, we start with the household, and then we end up at the facility. But at the end of the day, you identify those with TB, those who are at risk for TB and need IPT. So what are the challenges? So at community level, we have noted that caregivers lack resources to take the children to the health facilities. Yes, 40% are not getting there. We have picked them, but they are not getting there. There's minimal caregiver understanding on the importance of offering preventive therapy to a well child, and that is very critical. At health facility level, we have found that the healthcare workers really need continuous mentorship. Without it, the confidence will not be built. We do not have child-friendly formulations, and the low stocks of INH have also affected the preventive part of the project. And we do have a weak sample referral system. I acknowledge those that listed in no specific order. Thank you very much.
Thank you, Maureen. I think we're going to move on.
The next speaker is Sabina Fakale. Sabina's worked for many years in Africa. We worked together in South Africa, where Sabina was given the worst district and asked to assist with managing and improving the TB program there. And more recently, Sabina has been working as a UNICEF consultant in Malawi and Uganda, and she's going to present case studies from those countries.
Thanks very much, Marion. So I'm presenting on behalf of the entire team that was involved in developing the case studies in Uganda and Malawi. And basically, the aim of the case studies was to contribute to global, regional, and country learning about integrating childhood TB services within maternal, newborn, child health, HIV, as well as nutrition programs, using a health systems lens, so to speak. We used document review, we used internet searches and documents provided by the MOH and partners. We held bilateral meetings with key health actors at the national and district level, conducted facility visits, and also held participatory workshops at the national level in both countries. We used an assessment tool summarizing the assessment questions by theme, and the tool really combined a number of existing tools and frameworks on healthcare integration in general, also childhood TB benchmarks and standards and ICCM benchmarks. It was a very rapid methodology, though, because the time was very limited to conduct these case studies. We also looked at dimensions of integrated care at different levels of the healthcare system, using a framework that was developed by Valentine and colleagues. And we simplified those dimensions into clinical integration at the service delivery level, managerial and organizational integration at the district level, and systems integration at the national level. We also looked at factors that influence integration, and we categorized them as in this image, and I'll come back to that later on with the results of that. So just very quickly, we looked at Malawi and Uganda. These are just some data. I will not go into the details, but both countries are low-income countries. And if you look at the Human Development Index, they are ranked 163 and 173, respectively. Looking a little bit more detail at Malawi, where the incidence, estimated incidence is 193 per 100,000. The estimated incidence among children is 4,100 for data from the 2016 Global TB report. Courtney, oops, sorry, that was the wrong one. There we go. Courtney Yuen and colleagues did a study to estimate the numbers of children that would be needed to be targeted for TB contact tracing. And there you can see that for Malawi, about 21,000 children would require evaluation every year, and about 800 under 5s and over 1,000 between 5 and 14 years would have active TB at the time of tracing, and the others, small number HIV positive children, and quite a large number of contacts would require IPT. Similarly for Uganda, I will go through this a little bit quickly because Maureen has already presented this. So looking at the budget, Uganda has a 19% unfunded basically budget for TB, and relies heavily on international funding. So when we started doing the case studies, we discussed about what people's perceptions are around integration. So these are some of the perceptions. Integrated services that have a community-based provider who refers to a facility that can provide the services in a one-stop shop. Also a comprehensive package of services available at the service delivery level and offered to every child. Also, another perception, services that are routinely available, and that's specifically referred to the issue of having pilots, but the pilots are often not being scaled up to be routinely available. And also complete care for the child with a focus on child survival, where all services are offered in one package. We looked at policies and what is put into practice. So in both countries, the NTP childhood TB strategies are mainly implemented at higher levels of care, with limited implementation at district and lower level facilities and community level. Basically, the barrier is there, the lack of healthcare worker capacity, as Maureen has already alluded to as well, and limited access to TB diagnostic services. Also, TB screening and linkage to diagnosis, treatment and prevention should be offered in all child health, ANC, PMTCT entry points, but implementation levels are quite variable and limited to pilots. There are no tools really in place to monitor extent and quality of those services. There's no TB symptom screening in community-based services, and also, as Maureen also already said, no TB in nutrition services. In terms of contact investigation policies, that's basically based on identification of TB contacts and then requesting the index case to get her contacts to report to the nearest healthcare facility for clinical evaluation. In practice, that is mainly limited to passive contact tracing from those facilities that do initiate TB treatment. And preventive therapy, INH for 6 months, are provided to asymptomatic childhood TB contacts, under 5s or HIV children of any age, but the coverage is still low. In terms of service delivery, we found there's still limited decentralization, which leads to often multiple referrals and also out-of-pocket expenses related to transport to getting to the services. Interestingly, ART services and HIV services are further decentralized than TB services. Diagnostic tests are mainly available at health center level or district hospital level and up. And TB screening and linkage to IPT and TB treatment is available for HIV-positive children and implemented in HIV service points. Nutrition services have a strong link with HIV services, but there's no routine TB screening offered. And the current IMCI and ICCM materials have look at danger signs of cough for more than 2 or 3 weeks, which then prompt referral for further evaluation for presumptive TB in children under 5. And in Malawi, there was already a pilot conducted by Save the Children on the TB-HIV adapted ICCM. Just looking at the ideal continuum of care, where you will have identification of at-risk in the community, that is the ideal situation. So it links to the pathway that Anna has already looked at, and household TB screening. That would then require referral to this facility and screening at all entry points. I'll just go a little bit quicker here because I'm getting 2 minutes. Basically, that would then, the child would then go, if symptomatic, go through this whole pathway and hopefully ultimately be diagnosed and have a successful outcome. And this would also, just having some arrows here, indicating the referral that is needed to higher level and back to lower level. If a child is not symptomatic, hopefully that he would be getting IPT and then ultimately complete the course of IPT. Also referrals are needed there. We looked at health systems functions to see how these have been integrated. In terms of governance and leadership, there's a long history of vertical programming, but a very high interest to integrate and close the case detection gap. In terms of financing for TB is still very significantly donor dependent, and donors often have a limited flexibility, which is really perceived as a negative factor affecting the integration of child with TB. In terms of information systems, routine data on TB case finding are available and disaggregated by sex and age. Data on TB in children are otherwise only available in the HIV program, and other programs do not yet have an integrated system or tools to collect those data. The quality is questionable, and there's very limited use of data for program management. Looking at the health workforce, as we've seen, healthcare worker knowledge, skills, and confidence are limited at the lower levels, and training materials have been developed and are being rolled out. There are separate supervision tools, and other programs often have separate training as well. In terms of supply systems, also in Malawi especially, the supply system is highly donor dependent. Both countries are planning to transition to the new FDCs in next year. Lots of strengths and opportunities. I will not go through all of them, but basically in Malawi there's a strong collaboration between the NTP and IMCI, primary healthcare. There's various initiatives that have been very successful. There's lots of potential for integration. In Uganda, as Maureen has already shared, there's also quite a number of projects and experiences that are yielding positive results. There's also a very good collaboration between childhood TB in general, and maternal and child health. Coming back to those factors and that graph that I showed earlier, basically if you look at childhood TB as a health priority, the factors that were identified that influence integration in a negative way are challenges around diagnosis, lack of surveillance data, and the fact that childhood TB is not really prioritized. I will just show all of them so that you can just have a look. I think the slides will be available on the union website later on. Very importantly, the broad context. Obviously, poverty is a very negative factor, but the existence of the WHO roadmap is a positive factor that can help to think further about integration. Quite a number of needs to move forward with integration. There's a need for a coordinated framework with a guide on how to implement this. Further decentralization of services is needed. We need more comprehensive, more flexible and horizontal rather than vertical resource mobilization. Further capacity building of healthcare workers. At all levels, integrated supportive supervision and supervision tools, integrated reporting tools, and strengthening of childhood TB reporting and recording within the NTP and also in other programs. And of course, an uninterrupted supply of drugs, reagents, and other commodities, and the availability of child-friendly TB medicines. We heard in Kenya that actually the availability of the new FDCs has strengthened the entire program, which is really an interesting thing of how these systems all work together. In terms of service delivery, the referral system is a very important one, and obviously contact tracing will need to be strengthened. Community awareness to create demand, very important as well. In conclusions, these case studies really help to get an understanding of the possible pathways of integration. Collaboration and joint planning between the NTP and MCH and IMCI at national level set the scene for broader integration. Generally, integration is still limited to activities at the service delivery point and pilots. And then obviously efforts are limited by insufficient decentralization of childhood TB services. Other health systems functions will need to be integrated further. And for the way forward, strengthening the referral system, building capacity of healthcare workers at all levels, contact tracing and integration with IMCI and MCH, including HIV and nutrition, are critical. The case study full reports are available on the website, on the UNICEF website under working papers. And would like to acknowledge all these people for their participation and support. Thanks.
Thank you very much, Sabine. This was a very complex undertaking. Please note and hold your questions. We really want to have time in the end to think about everything you heard and talk about it comprehensively and about the topic together. So next I'm introducing Avinash Kanchar. He works at WHO in the Global TB Program in the TB-HIV team and has been leading the effort to start developing tools for maternal and child health integration with TB.
Thank you. And good afternoon, everyone. So I'll start with some of the data that came out through the recent WHO Global TB report, and we have worked on a fact sheet extracting data out of that, and the situation still remains very grim, with more than 3.5 million women getting tuberculosis in 2015, and consequently affecting very high risk of mortality, of low premature births and low birth weight, perinatal deaths. And we all know the HIV, in high HIV settings, tuberculosis is responsible for 15 to 34% mortality due to indirect causes. There's also a lot of mortality amongst children. More than 210,000 estimated deaths occurred among children. So looking at these statistics and learning from the examples that we heard from Uganda and Malawi, is we are trying to put together a framework which countries could be able to use to implement integrated services in a programmatic settings. So I'll just provide a glimpse of the thought process that is going into development of this guidance, which we are calling as a toolkit, which would include all the existing WHO guidelines and the country experiences. And we also learn and draw our experiences from the other work that we have already been doing. For instance, collaborative TB-HIV activities, for which we have a lot of experience of working with the HIV programs systematically. And we have a project which we call the Engage TB approach, which we implemented in 5 African countries, from which we have some experience of integrating TB into the work of the NGOs. And then we draw experiences such as the ones we heard just now. So what we are suggesting is efforts at the 3 different levels. One is at the level of the national policy and development of the national guidelines. And this is not limiting to TB guidelines. It's moving on to the maternal health guidelines, PMT-CT guidelines, IMNCI guidelines, and ensuring that basic TB services are at least incorporated into these guidelines so that they can percolate through the trainings to implementation. What is critical is also to establish mechanisms for collaboration. We know from our experience with the HIV programs that if we have mechanisms which allows the policymakers, the program managers, and the implementers to be able to interact at a very regular interval. It helps in removing the bottlenecks and improving the monitoring and evaluation. So we need mechanisms of collaboration to be established. And then at the service delivery level, as speakers earlier alluded to, we need a one-stop shop as the main aim of looking at the public health sector, as well as at the community level health services. So for national policies and guidelines, before we are able to formalize our thinking for the toolkit, what we are doing is looking at existing national guidelines, RMNCH, PMTCT, and child health guidelines in countries. And one of my colleagues who is in the room is doing that. And we have some preliminary understanding of what's happening in countries. And these are 12 countries which are among the priority 30 TB-HIV countries, all of them in Africa. And what we see encouragingly is almost all of them have TB services included in the PMTCT guidelines. And most of them have it in the antenatal care services, except for Botswana and Malawi. So these guidelines, they do say that TB should be, TB symptom screening should be conducted at every visit for pregnant women who are HIV positive, or during the antenatal care visit. For IPT as well, 9 out of 12 countries do have some recommendations suggesting coverage of IPT. Some countries are not very clear in their guidelines, but this looks very encouraging. That most of the countries do have something in their guidelines, but we are not sure if this is getting translated into implementation. Regarding collaborative mechanisms, we are largely looking at the collaborative TB-HIV activities, and the mechanisms we had were sort of national technical working groups which got the stakeholders from TB program and HIV programs together. So what we are suggesting is to use the same platforms and get the other stakeholders from maternal health and child health programs on the same platforms, and have similar structures at the regional level and at the facility, district levels and facility levels for the policymakers and the program staff to be able to interact and share information and discuss the bottlenecks in implementation. What is also important is collaboration at the time of planning, which was alluded to previously as well, and there are opportunities for joint training and capacity buildings which should be looked into. We also have, as I said, experience from implementing TB services at the community level, and what we learned from that principally is having a NGO coordination body at the national level with the NGO stakeholders and the national program stakeholders. It helps in implementation at the community level as well. Service delivery, similarly, we'll have to consider both the public health facilities as well as the community and various players that are there, and not only those who are already engaged with the TB programs, but unengaged NGOs should be the ones that we should target, because many of these unengaged NGOs with the TB program, they work in various aspects of the developmental sector, and they provide services for women and children. So these are the ones which we should target, and we have some good experience of engaging them. So the framework is looking at the entire continuum of care, starting from pre-pregnancy to during pregnancy period and postnatal and motherhood. And so the entire cascade and various service delivery options that are there, we should target all of them and try and integrate basic services, and may not be very complicated. It could be just basic screening and mechanisms to link with the other services which may be available in the nearest public health facility. So we try to map the array of options that we have and including at the community level, the existing services that are provided under RMNCH, and which we would reflect in the guidance that we are developing. But the key here is, as someone else also said, is not to disrupt the existing services. So it's crucial that we try and put the elements of TB into the ongoing work of either the health workers or as well as the community. So we are suggesting an integrated and minimalistic approach. But what is crucial is to have recording and reporting mechanisms. And we found that to be the most challenging element when we work with the communities. We are looking at experiences of countries in the programmatic settings, and this is one that the Population Council conducted with USAID support in Kenya in the primary healthcare facilities. And under this project, TB screening and referral was integrated into the antenatal care services. And at the end of it, they found it to be feasible, and there's a lot of capacity with the antenatal care facility staff, which could be harnessed, and that. If a focus is brought to this activity, the referrals would increase, and the yield of TB is very high. Up to 5% of all the clients from these facilities were referred during the period of the project. But the challenge that was highlighted was, again, standardization of these interventions across the various services. And there are several others which I won't discuss, but we know that PMTCT could be integrated in many MCH programs, and we could learn from that integration efforts. So there are several publications out there, and we heard a couple today. So we are trying to draw from these experiences to develop the framework that countries could use. I'll share a few slides about our efforts in the community engagement. We had this project called Engage TB project in 5 countries in Africa. And a total of 12 NGOs were involved, which collectively covered a population of about 8 million. And out of these 12 NGOs, 5 had RMNCH as one of the key areas of work. And these NGOs were working in different fields. Most of them had HIV and RMNCH as the focus, but there were NGOs who were working on education, agriculture, livelihood development, water and sanitation. So different mandates, but there is readiness to take on simple, basic TB services and provide services to the clients. And there was a range of services that they could provide, starting from behavioral change communication to sputum collection and transport, to providing transport support for the clients themselves, and to dot provision, as well as helping with the supplies. So there's a range of services which the NGOs could bring in this integration effort. And I'll have last two slides which give some sense of what we get out of this. So what we see is these are the 5 NGOs I mentioned which had RMNCH into their services, and what we see is where the public health system is lacking or very weak, these NGOs are able to contribute a lot. If you see the last 2 bars, they are from Ethiopia, and these are very difficult areas where very little public health services are available. And the NGOs with these efforts in 2 years, over the period of 2 years, contributed about between 30 to 60% of notification in the area, which was an addition to what was happening in the past. In terms of outcome, we could get data only from 2 out of this, because, as I said, this is the most challenging, to be able to document their work and get it reflected into the M&E systems is very difficult. We couldn't get data from all. for all the quarters, but we have from 2 NGOs, and what we see is very encouraging, and the case holding is spectacular. More than 90% patients completed the treatment. So engaging these NGOs who are already present and doing other work is very helpful in both increasing the notification of TB among women and children, as well as case holding. So to conclude, integration into the RMNCH is feasible, including at the community level. And but what is critical is to establish mechanisms for collaboration and having NGO coordinating bodies, structures which are proven to be very helpful within the TB-HIV work. And there's a lot to be needs to be done to strengthen the monitoring system and keeping them very simple and very basic, so that we are able to gauge the contributions. Thank you.
Thank you, Avinash. I introduce or invite our final speaker, Marianne Loveday. She introduced herself. She works at the MRC in Cape Town, and we met each other when I was looking for people who understand health systems better than I do and can help us to think at childhood TB really from a different perspective. So thank you, Marianne.
So when I started to think about health systems and integration, I got a picture in my head of endless arrows that ended up a bit like spaghetti with rather a dark sauce on. So I thought that wasn't the place to start. So I'm rather going to start here. This is where a little guy that I've had quite a lot of contact with over the last year comes from. He was diagnosed with MDR-TB in South Africa. His family live in this rural homestead with this rather broken down greenhouse, and the school is over the hill, which is over the hill, which is over the hill, and when it rains, no vehicle can get there. So I just wanted to show you this family tree. This is the people who live in the household. Oh, I'm sorry, wrong button. That's his father. His father's in a light blue box. Everybody in the light blue box is infected with HIV in the household. This is the little guy over here. He's in a purple and a light blue box because the purple box represents MDR-TB, and he's co-infected with HIV, so the bottom of the box is light blue to show he's also co-infected with HIV. His mother is HIV positive as well. He had an older sister who was diagnosed with XDR-TB in 2012. She died a year later, so her box is ringed with black. And then he's got a little brother who is infected with ordinary TB, so his box is green, representing ordinary TB. And the reason I really wanted to show you this slide is to contextualize the burden of disease that a family in many low-income countries will present with, as a way of understanding what our health system how our health system has to respond. Also living in the household, or not living in the household anymore, was the aunt who died of HIV a couple of years before, and the uncle who disappeared. Nobody knew his HIV status. But there were 2 other children from that family. The cousin was of a little girl of 7, was also co-infected with TB and HIV, and the little guy, luckily of 8, was not infected with TB and HIV. So this was who lived in this household. And so the question I asked myself is, how are we to provide effective MDR-TB services to a family with this burden of disease in a rural setting with limited resources? MDR-TB is a complex disease, and it requires a comprehensive health systems response. So for effective MDR-TB management, we need functioning and integrated laboratory, pharmaceutical, and transport services to be delivered to this little guy in that household, which is over a hill, which is over a hill, which is over a hill. Now, in our country, and I think in many countries in Africa and in the rest of the world, the district is responsible for providing healthcare services. But in our country, the district health services are overwhelmed with the TB and HIV burden. You saw from that family what they have to address. Not only that, but at a district level, there's often poor leadership and a lack of accountability at a facility level and at the district level. And the district health services are expected to provide maternal, child, and neonatal health, TB, HIV, and chronic services, as well as deal with acute health issues and the fact that somebody gets drunk on a Friday night and stabs somebody else with a bottle or something. And then at the point of this triangle is this little guy. He's part of a household, he's part of a community, and he goes to the local school. So in trying to think around how are we to deal with this issue, or the only way I can come up with is we have to turn the triangle the other way around. And unless we are to get totally overwhelmed by the enormity of the task at hand, I believe we have to focus on the child. And instead of focusing on the complexities of providing effective MDR and the myriad of services that have to go with that, we must focus on caring for the child and providing patient-centered care. So it's quite opportune that I talk a little bit about this because care and patient-centered care is one of the pillars towards the end TB strategy. So what is care? Care is a relationship between the one caring and the cared for. It is a relationship of concern in which the other's existence matters to you as the one caring. And then, at a second quote, effective caregiving requires more than intent or sentiment. It requires being in relation with others. And then moving on to what is patient-centered care. It means putting the person of the patient at the center of the consultation and attempting to understand the patient's thoughts, feelings, and expectations, as well as his or her symptoms. And it demands a shift from thinking and responding in terms of disease and pathology towards understanding and caring for people and their problems. Now, the reason I know about this little guy is he was hospitalized at our big drug-resistant TB hospital in KwaZulu-Natal, and I was wanting to explore a potential other study, so I wanted to speak to his mother. So Mrs. Buthelezi and I spoke for about an hour and a half. So I was asking her questions, and it was a very informal chat. She was waiting with her son to attend to the clinic, and I was asking her about her life and the family and her household income. And at the end of the hour and a half, and we had a great time, she talked, and at one stage she even cried. At the end of the interview, she said to me, "If somebody talked to me like this when my daughter was alive, she would never have died." And I was appalled. I'd spent the time asking her questions. I hadn't been answering her things. I'd been asking her things, but I'd been talking to her. There was an aspect of a relationship. And she was quite tearful at the end. Anyway, we're now best friends. So how do we move towards integrating community and primary healthcare systems to improve outcomes for women and children? The first thing is, I believe we've got to be patient-centered care. If our starting point is the mother or the caregiver and the child, the integration of the different programs will fall into place. And the second thing is we've got to learn from different programs. I think the trouble is we all have we're so vertically minded that we're not talking to the maternal and child health program and finding out that they've got exactly the same problems with us. And we're not learning from them that they have come up with some quite innovative ways of dealing with those problems. Instead, we just focused on TB and our failures and that we're not managing to get there. So what are some of the common challenges? all programs know that we have to integrate with other programs. So, but all of us different programs have different philosophies, different guidelines, different platforms, different funding mechanisms. The one thing that drives me to distraction, and I'm going to keep saying it and probably will keep saying it till I die, is they keep on at us about TB and HIV integration. We still have DOT here and treatment adherence here. How are community-level health workers in a community, when they visit a house, supposed to deal with these two different philosophies and two different approaches to adherence? It just doesn't work. The second thing is the interface of different levels and different functions. I think numerous studies have been undertaken that show that it's at different levels and different interfaces that patients fall through the cracks. We know that, so we need to focus our attentions at those different interfaces, at the different levels. Between the hospital and the clinic, people fall through the cracks. Between the clinic and the community health worker, patients fall through the cracks. And we've got to develop systems to stop patients falling through those cracks. The third thing is community health workers. I worked in a community health worker program for 10 years in the 1980s, and when I left that program, I said I was never, ever, ever going to work with community health workers ever again in my life. And here we are in the 21st century, and we're not dealing with things very well at a facility level. So what's our solution? Make community health care workers who paid a pittance of a salary deal with more and more programs. So community health workers are expected to do with maternal and child health. They're supposed to deal with neonatal ICCM. They're supposed to deal with all these WASH things, to deal with sanitation and all that kind of stuff. They're supposed to deal with TB. They're supposed to deal with HIV. We're not paying them properly. There's no accountability. There's very limited supervision. I think we really need to think carefully about this. The next thing is quality of care, support and supervision. We really need to focus on how to improve quality of care and how to get there. I'm not coming up with any major solutions. I'm just saying it's a problem and will continue to be a problem. We're going to just carry on breeding resistance unless we deal with quality of care. Referral pathways in every single program are a problem. If I can't cope at this level, how do I refer the patient adequately to the next level, and when will ever there be a letter coming back telling me what happened at that level? And then, of course, there's accountability at a facility level. There's a terrifying article written in about 2012 in Zambia that describes how the care at a facility level is undermined by the lack of accountability at that level. And then, of course, the last point I've got there is donor funding, which is seldom for health systems or for care overall, but tends to be program-orientated and with very specific outputs and outcomes, which limit very much sort of integration and involvement of the whole healthcare system as a whole. So the way forward is if all programs together could focus on patient-centered care and address their common challenges, I believe we would achieve considerable integration. So thank you.
Thank you, Marianne, so much for that reality check with that story. I think I did, and I hope that you did, hear a common theme in what we were talking about here, and from both the global perspective, but also very much so from the country perspective. So please share your questions. I maybe Avinash, Sabine, Maureen, come here. I take the microphone, or do we have a microphone? And run around. And share your thoughts and questions and suggestions on what we can do.
Maureen,
you can sit up there. Rudy.
Thank you, Anne. I think two comments. I think in this entire conversation, we kind of are sort of dancing around quality, but I think putting the spin of quality onto this whole topic is important. And I think very practically, you take something like severe acute malnutrition, you catch a severely malnourished child in a high TB burden setting. With TB early, you probably are going to cut the needs for long-term nutritional support quite dramatically. So on one hand, it decreases costs. On the other hand, it begins to improve the quality. And I think about things like pneumonia, maybe being more aggressive in the wards. For those children, you more quickly pick up the TB and more quickly you have a better sort of management. So I think that's one element. I think one of the problems, this whole business of the integrated care, I think what the programs are doing is, so we go very targeted for ICCM with a very focused set of questions, approaches. We go very targeted for FANC. So what we're teaching people to do are these very targeted clinical interventions, but they're never brought together, they're never connected with the other pieces. And I think that's really quite disruptive probably at the moment.
Thank you, Rudy. I think that's exactly what Marianne was saying too. It's the child that is sick and it can have anything when you start seeing it, and you don't start seeing it by thinking HIV or TB.
Thank you to all the presenters. I think my question will be more focused on the gentleman from WHO, but all the other members can contribute. Sorry, I don't remember your name. I am interested in finding out more about this integration of TB screening in specifically antenatal and postnatal clinics. As you may all know, most of our antenatal and postnatal clinics are run by midwives. So when we talk about integration in these clinics, what are we really talking about? Are we telling them to screen and refer, though we know that many times when you refer patients, they do not reach where you want them to go? We are talking about a one-stop shop, but are these midwives, do they have the capacity to screen, diagnose, and treat mothers? Also, we've seen a challenge where people don't think that mothers have as much TB as the attention we are giving them and the focus. So how do you deal with those issues? Thank you very much.
Thanks for the question. I think you have raised a very, very critical issue, and that's why I presented two aspects to integration. It would be the health, public health system as such, and as well as the community players, and there are several that we probably don't tap at present. But I would agree there would be limited capacity at the field level, and that's why WHO is suggesting only symptomatic screening. So we are not talking about elaborate algorithms. We are talking about asking few questions, and trying to establish linkages with the nearest available facility. And I understand in some cases it may not be very near, but that's why the emphasis is two way. One, not to disrupt what's already happening, and two, to be very simple in what we are advising at those levels.
Thank you. I think you also touch on two things. One is the general awareness and understanding, and that needs to start in pre-service training. So how can we influence education curricula? And then implement simple tools to not, because the first reaction is by other providers, so hold on, TB is so difficult to diagnose and so on, but that's not what we're talking about, and I think we have to be very clear with that message. But you need to think about it when you see that pregnant woman in a high TB burden setting, or when you see that malnourished child, and that is quality of care. And then the other thing is the elephant in the room, which is referral systems, as you mentioned too, Marianne, but that is something that each and every program is struggling with, and so we need to put our heads together on how that can happen.
Thank you. I am from World Vision. My question is to Dr. Sekam from Uganda. Probably more of us, presenters here, know that Kenya has already rolled out, and they are in the process of rolling out FDC for TB treatment in children. If you can briefly update us on Uganda NTP plans on that. Thank you.
Thank you so much for your question. So we do have a pipeline of old formulations that is taking us through about April 2017. So for purposes of not wasting, we've been working with the GDF WHO team in Geneva. So the agreement was to move forward with this pipeline, and then we expect the new formulations about May or June. So we have done our quantification. We do have a scale-up plan in place, and we are working closely with the GDF and WHO TB Alliance in moving the PID formulations into the country. So we hope to roll out in June 2017 about that.
Thanks, Maureen. I want to make one more comment to what Maureen presented from Uganda. So you see two projects that aim to better integrate and decentralize childhood TB. So the one is the Union project that works with community health workers, and that is mainly led by Maureen and the TB program. And then there is and they focus on contact screening. And then there's the other project that's being started now that is mainly led by the maternal and child health people in the ministry in collaboration with Maureen, that is focusing on the community health workers that do ICCM. So, but it's the same community health workers. One district is overlapping for both projects. Right now, it's two different projects. One is already having a huge success, and there's commitment for scale-up, and there needs to be funding through the Global Fund or something else to scale it up. But the next big question, and that's the systems question, is how can you scale these things up together? Because you're working with the same community health worker. How can you merge the tools? How can you be more comprehensive in these efforts? And that's a concrete question there, because there are two projects, there's commitment at the ministry level to scale both up, but how can this be moved forward in a more comprehensive and actually scalable way? So just more food for thought. Any other comments, questions? From your side? Is it possible that we're ending early? Yes.
I wanted to ask about the funding from the last presenter in particular, but the issue seems to be, I've done work looking at maternal child health funding and how increasingly programs and projects are now outsourced. So you get complex, this is in the context of Nepal and Malawi, very complex assemblages of organizations with various functions outsourced. And that'll be the maternal child health bit. And then you've got the other bit. So if we're talking about scaling up together, for example, as you said, how can that be done when there seems to be this trend towards projectization, increasingly complex assemblages and consortia of funding? I just wonder if you had any thoughts about that at all.
No, not really. I might be in line for the Nobel Peace Prize if I had. I mean, it's such a big problem, and I think the problem also with a number of grants and things is that they're becoming increasingly complex. If you think of that, they're so often given to consortia now. So, there's sort of dynamics even occurring at that level, let alone at the country level. I suppose that's why I wanted to start at the opposite end and just start with the child and the household, because at the end, it's all about what happens there. So I'm not offering any clever solutions, just saying that is a problem, and the way that donor funding comes in at the moment is complex. And at one level, you sort of think, well, maybe if countries had more of a say or wielded more power and said, well, we can't have two similar granted funded projects coming in the same district, maybe that would have a difference. But that also is open to abuse and things go wrong at that level. So I've just got more questions actually than answers.
But I think one thought is also that there needs to be really more dialogue and forcing the donors a little bit to think differently, and say, and for the programs in the countries to take ownership and say, this is what we want to do and we need the money to do it, not you want to do HIV and give us the money and then we do what you want us to do. It was interesting in this meeting that we held in New York, funding and the challenge with vertical funding and the lack of resources came up in each and every discussion several times, so that at one point the donors that were in the room said, yes, we know, we contribute to vertical funding, we need to work better together. We're now actually having an active dialogue at USAID with the TB people, TB team and the maternal and child health team. And this morning I had a very interesting conversation because the people from the TB team said, so now that we can actually start talking with the new maternal and child health team, because we've tried to reach out to them before and they haven't talked to us, was really interesting. That you know, it's about facilitating bringing people together and also bringing the donors together in a different way and challenge them. And with just one last example, there is how to use disease-specific funding. So the Global Fund has an MOU with UNICEF, which aims at using malaria funding to scale up ICCM, so to strengthen this, at least part, I know it's still somewhat specific, but part of the community platform. There's now 22 or 29 countries in Africa scaling up ICCM. There are over $200 million mobilized through malaria funding for strengthening of that overall community platform. And I think that's one idea to negotiate with a donor to be more flexible.
So maybe it's the quality of the vision that we are selling as a problem. And I want to go back to antenatal care. So we are talking about integrating IPT. I know the malaria folks are talking about the other IPT, which is IPTP for malaria. So they have the same issue, but we're seeing other folks are dealing with iron and folic acid. That's another issue. So then what is the solution to that? And should we not be going, and I think this goes back to what Marian has been saying, to the patient and dealing with the patient. And if we get antenatal care right, then maybe we get all these things right. Rather than, I know IPTP very well, it's been reduced. We must do A, B, C, D, but they're still not getting it right despite a lot of investments.
Anyone of you want to comment on that? Or?
Hi, I'm Amy Israel from Eli Lilly. We have the Lilly Foundation, and we have been part of the problem in the past for vertical funding. And we used to until the end of this year, I guess. We will have the MDR-TB partnership and our NCD partnership, and someone doesn't have MDR-TB and not affected by an NCD, and we haven't been integrating our funding, so how can we expect other people to integrate their services? We are trying to solve our problem, and this is not a push for Lilly, but what an ask for you all is be strong with your donors, because we need to hear stronger messages of this isn't going to work. And I come from the NGO background where was always trying to fit a grant proposal into the needs of the funder, and I'm not kind of meeting the needs of the patient population, but not really. You can say no, and this is what we need. And some funders will go away, but most, I think, will be realistic and hear you. And maybe it's a pipeline dream, but you know, there used to be the PEPFAR floor and the Global Fund floor in the warehouse, and that is no longer. There's coordination. I think there's an opportunity for us all. And as long as all of the donors are aligning with each of your country's national strategic plans and filling in the gaps of those plans or the needs, then we should be okay, but it's a challenge.
Thank you, that was a great comment.
And I wanted to comment on a question you asked, how do we put all these things together? And I think almost all the speakers kind of hit at it. You look at a program where we want this community health worker who is a volunteer to go into the home and do malaria, going to the home and do nutrition, but there is nothing integrating everything. But you want them to do all these things separately, and they are not being funded. So why don't we start by integrating all these things at the community level? Like she said, the donors have kind of driven the way government programs are run. If UNICEF comes today, they want ICCM, no offense, we shall focus on that. If tomorrow another funder comes, they want us to do this, we shall focus on that, funding will be that. If tomorrow it is saving lives, giving birth, they'll follow up the pregnant mothers, but they forget because that is where the funding is. So maybe the programmers and the funders all need to agree that we are integrating. This community worker needs to be supported. I've seen it in Uganda. We expect these village health teams to do so much work but pay them nothing. So everything is taken, send it to the VHTs, send it to the VHTs, but no one is paying them anything. No one is willing to include them in the structure, in the Ministry of Public Service to pay them. So how do we expect them to deliver, though we know that service delivery will work if it's at the community level?
Yeah, thank you. I think you touched on many points, and one is if we really want to put everything on community health workers, they have to become part of the formal system and be properly paid. And then there are all the supportive system that we need to include in that. And yes, we need to sit together at the program level and think what are the issues, what is the package of services that needs to be delivered at each and every level, and how can we make sure that conditions that cannot be managed at the lowest level are at least recognized, that a community health worker knows this triggers me to, I can't deal with this, I need to send it somewhere else, make sure the sending somewhere else actually works. And then the next level has the next, package of intervention and the right support to that, and that it's coordinated so that it doesn't happen as you see, because also there are few community health workers, and it's not that the work is evenly distributed right now amongst them, right? Each and every program knows which are the good ones amongst the ones. So we select the 2 that are known to be good, and then they get to dump everything on. So how can this be changed? So, and then I think it only changes if there is a dialogue at the top level to decide what it is that they want to do, and then be able to support with funding what they want to do, but be, as our donor said, be more demanding and clear in expressing that. But for us, I think it's also important to really think about how we talk about it, because we still always go in with the TB perspective. So we go and to listen to the issues of the other programs and where there might be the opportunities to address TB, or not only the opportunities from our perspective, but why there is a need from their side to look at TB, because it affects the malnourished child, on whether it can be managed at the community level or needs to be managed at a higher level to survive.
Can I make a small point? I think I want to reflect on what the previous speaker said about funding and the need for supporting the community health worker. I have been part of the Global Fund discussions over the last funding cycle, and the new one is coming up very soon. And there was, countries were encouraged to articulate needs for community system strengthening, and requested to put in budget lines for that, and many countries struggled. I think that is one opportunity where TB, HIV, MNCH, health system strengthening, these are various components that are part of the Global Fund application. And if we could articulate the CCM, the country coordination mechanism, or the national programs, if they could sit together and see what are the efficiencies that could be drawn, and what would be the funding need like if we want to integrate these basic services. So, and if that could be part of the proposal, I think that some of it could get funded, and we could offer some support.
I have no clue what time it is. Any other? There is something.
Thanks very much. I'm Paul Nunn, an independent consultant. I agree with what a lot of people have been saying, that at the end of the day, it does in fact boil down to community health workers, I think. And if they are underpaid and inadequately recognized, the only solution, I think, is to the government recognizing them and adequately paying them. And one country, I think, where that's happened is Ethiopia. Back in about 2003, Ethiopia decided to pursue, actually before then, health extension workers. So they would have 2 female workers in each kebele, which is about 5,000 people, so 2,500 per worker. And it is at that level. They have a 16-point package, mostly maternal and child health care, quite a lot of hygiene activities around. And they've been really effective in reducing child mortality, particularly from diarrheal disease, and also from acute respiratory infection, although there have been some problems. However, some things were not falling, like, for example, maternal mortality rate was still astonishingly high. And what was decided around about 2010 was to try and get health issues right down to the community level, to every household. And the Ethiopians started what in some places is called the Health Development Army, and in some places is the Women's Development Army, whereby every household, the woman in every household is brought into a group of 6 households and works with the health extension worker over a period of, I think it's 96 hours of training. And then they keep on meeting once or twice a month with the health extension worker, focusing very much on pregnancy, outcomes of pregnancy, ensuring institutional delivery, improving maternal and child health care, making sure TB treatment is continued, making sure ART treatment is compliant, and so on. And it seems to have very impressive effects. And the health extension workers are paid. They are salaried members of the health service. There are all kinds of problems now about how they work their way up the system, and solutions are being generated for that so that they can climb up the different levels in the health system. But I don't think there's any alternative to doing that. If you've got limited roads, limited capacity, the vertical type programs, the maternal and child health programs, the TB program, cannot get down to the level required. The only group that can is the community itself.
Thank you, Paul. I think Ethiopia is the example that's always given, and countries, I think, including Uganda, are trying to adapt their system to reflect more the system in Ethiopia. I know that one issue in Ethiopia is demand. So there are experiences, at least from child health, that there are community health extension workers or even health development army, and the services are not utilized, so we cannot forget about that part. And that's, I think, very strongly where the NGO and the supportive community systems also come in. And then, yes, there is the package that they have, and what do we add, and how do we do it in a concerted way, because everybody wants to add onto this package there, right? But I think you're absolutely right. So I think it's time to close this. Thank you all very much. I hope this stimulated your thinking and didn't frustrate too much. I hope that you all carry these discussions on and carry them on outside of our community and our family, because that's the people that we need to talk with and understand how they think and how we can work together. So I have a few copies of the report from the meeting that we had in New York if anyone is interested, but the meeting report and the case studies are both on the UNICEF website. Thank you.